Uh, it is my pleasure to introduce Dr. Allison Navis, who's an assistant professor in the Department of Neurology, Division of Neuroinfectious Disease. She completed her residency training in Mount Sinai Beth Israel and her fellowship in in the Neuro HIV division at Mount Sinai Hospital. She's been involved in global health work in Zambia and provided neurology teleconsults to Doctors Without Borders. Her research focuses on the effects of HIV on the brain with an interest in immune reconstitution inflammatory syndrome. And today she's going to talk about the central nervous system infections and the immune response. So thank you so much, Dr. Navis, for talking to us, and I'm looking forward to your lecture.
Thank you for having me. All right, I will dive in, but today I'm going to be sort of talking not specifically about infections of the central nervous system and the damage that infections themselves can do, but more the complicated interplay between the immune system, the inflammatory responses against infections, and the role for immunotherapies. So, in terms of disclosures, I don't have any financial disclosures or conflicts of interest. I will say that I will be discussing off-label uses of medications. Pretty much anytime I'm talking about treatment, it's an off-label use since there is no standard treatments for any of these things. So that is the one disclosure. So an introduction to the topic and sort of to myself, as mentioned, I'm a neurologist by training with a specialization in infectious diseases and HIV of the CNS or brain. In particular, I'm not an ID doctor, but my particular interest is in iris and sort of the inflammatory response to infections. And so to sort of start off the talk, I wanted to talk about a patient that I had many years ago. This is patient S. So she's someone who was diagnosed with cryptococcal meningitis. I met her for the first time in outpatient follow-up in the HIV clinic. At that time, she was doing well. She had initially come to the hospital with some headaches, vision changes, hadn't been taking her HIV medications. Her CD4 count was low at 10. She had AIDS with a high viral load. She received treatment for the cryptococcal meningitis, and when she came to see me as an outpatient, she was doing quite well. She got a follow-up MRI that was non-focal, didn't show any signs of active infection or inflammation. And then several months later, she was readmitted for confusion. Her husband brought her in the emergency department. She was, essentially obtunded. She was intubated to protect her airway. It was unclear sort of her adherence to her fluconazole for the cryptococcal meningitis. And her CD4 count was a little bit higher than sort of initially. Her viral load was a little bit lower. So it looked like maybe she was taking her antiretrovirals, but there wasn't sort of a huge change in terms of her CD4 count. And she had a workup for why she was coming back into the hospital. And she had an MRI that showed sort of this very diffuse, thick leptomeningeal enhancement around the brain. Her lumbar puncture study showed this lymphocytic pleocytosis with elevated protein, and her cryptococcal antigen titers in the CSF were still very high, sort of on par with her initial diagnosis. Otherwise, her cultures didn't grow anything. All the other studies were negative. So it was unclear if this was sort of a relapse of the cryptococcal meningitis or if this was iris. She got repeat induction therapy nonetheless without any response. And she just became, progressed and was sort of very critically ill. So her hospital course was complicated by ventilator-associated pneumonia. She developed a sacral ulcer that needed debridement. She had bacteremia from the sacral ulcer. And her mental status never improved. And so eventually she was trached and pegged and sent to a long-term care facility, still minimally responsive. And so throughout this entire course, again, the diagnosis, exactly what was going on remained unclear. She seemed to have this sort of meningitis, but whether it was infectious or inflammatory, we didn't know. We couldn't really get a biopsy because she was so sick. And I think this sort of highlights the complications with these types of patients and why I wanted to sort of talk about this today. And that, patients with central nervous system infections, they're oftentimes very critically ill. They also, though, can have these strong inflammatory responses. I find that these patients tend to be some of the most difficult to sort of diagnose and manage. And so oftentimes the questions that I get in terms of patients either with opportunistic infections and a question of iris or with potentially unknown central nervous system diseases where an infection is on the differential, sort of how to manage this, how to approach it, whether immunotherapies are beneficial or are they going to potentially worsen infections are sort of a very common concern here. And so my sort of underlying interest in IRIS, these patients who are quite ill and end up getting sicker with immune reconstitution, as well as sort of these more complicated like other infections, sort of stems from this. And I think this is relevant to sort of across the board, the critical care group. Again, they're critically ill. They're not always just with nervous system infections. Many times these patients have systemic infections. They've been hospitalized for the long term with complications. And so they can be sort of in the ICU, intubated. You can see sort of these autonomic storming responses to these patients. And the diagnostic workup and sort of management is unclear. So I'm going to be talking today about sort of this immune response to these infections. I'm going to be going over sort of IRIS. I'm going to be talking as well about immunocompetent patients that can have sort of these complicated immune responses to infections, focusing primarily on viral infections in immunocompetent patients, and then sort of discussing the overall approach to workup and management. All right, so starting with IRIS. So IRIS sort of is a term that first came into existence, I guess, in the late 1990s, early 2000s. And so it was in the late 1990s that we had combination antiretroviral therapy that was starting to be widely used. And at that time, people with AIDS who were starting on their antiretrovirals, we were seeing case reports of, despite their immune system improving, they were becoming sort of sicker with these atypical opportunistic infections. Sort of unclear what was going on, but further studies showed that there seemed to be sort of this strong inflammatory response to an underlying infection, oftentimes infections that we typically didn't see, causing clinical deterioration. And as more work went into this, the term sort of immune reconstitution inflammatory syndrome, or IRIS, was coined and sort of named at the Infectious Disease Society of America meeting in 2002. And since then, when we talk about IRIS, oftentimes this is in reference to HIV, people with AIDS who start taking their antiretrovirals and have immune reconstitution, but it doesn't just encompass them. It's anyone who's immunosuppressed who undergoes immune reconstitution. So this can include like our multiple sclerosis patients. And this is also more generally an umbrella term that probably describes things like the Jarisch-Herxheimer reaction to specific infections that has been sort of known for much longer than IRIS. So it's sort of an umbrella term to this immune response that we can see that's triggered by sort of underlying pathogens. So it's very unclear what causes IRIS. There's a lot of disagreement among sort of people looking into this. The general idea here, again, the specifics are still unclear and without a lot of debate, is that you have someone who's immunosuppressed, and so they have either low or absent cell populations. This is going to be your CD4 cells in your HIV patients. And then as they develop immune reconstitution, you get these increasing cell populations, but the immune system doesn't come back necessarily, in an appropriately regulated way. You might get sort of increases in cell populations that are disproportionate to what they should be. And so you have this very dysregulated response. You might have this uncoupling of the innate and adaptive immune systems. And all this sort of leads to this pro-inflammatory or hyper-inflammatory response, oftentimes triggered by pathogens in the body that might not be at sort of critical levels to be causing clinical symptoms, but this hyper-inflammatory response against these pathogens that can then trigger clinical deterioration. And so my particular interest with IRIS is sort of the challenges in diagnosing this. So IRIS can happen anywhere in the body, including the central nervous system, which is where my interest is. But there isn't great diagnostic criteria. So, the diagnostic criteria is sort of what you see here, which is, vague at best. But it's typically going to be sort of clinical deterioration in the setting of evidence of immune reconstitution. So for our HIV/AIDS patients, this means decreasing viral load, evidence that the antiretrovirals are working, and usually an increasing CD4 count. There should also be an immune response against an underlying pathogen, spontaneous resolution without specific antimicrobial therapy. So both these things indicating that this is more of an inflammatory response than, primary infectious issue, and no other explanation for clinical deterioration. And the challenges here is, I say this is diagnostic criteria, but it's not clearly a diagnostic criteria in the sense of how vague it is. It's more sort of a guideline for the clinical judgment that we use. But this can be sort of challenging to apply anywhere, but especially when we're talking about the CNS, it becomes even more challenging. So particularly, what do we mean by an immune response against an underlying pathogen, sort of in a clinical situation? How do we diagnose this? We might look at inflammatory markers, but those might not be very helpful in telling us what's going on in the central nervous system. Neuroimaging might be helpful, but there can be a lot of overlap between an inflammatory response and an infectious response. And this no other explanation for clinical deterioration can be challenging, especially with these neurological patients. And that, a lot of different systems in the body can cause neurological deterioration. And so sometimes it can be challenging to say that someone who's getting sicker, even though we know there's something going on in their brain, they might also have hyponatremia or other systemic infections. They might be having seizures. How do we know it's not these other things that are causing this deterioration and not from an inflammatory response? And so again, this is very vague at best. And the spontaneous resolution without specific antimicrobial therapy can be hard because IRIS typically occurs in the setting of an underlying pathogen. And so oftentimes that might be treated, but not in every situation is someone already on treatment for that. And sometimes we can't sort of have a watch and wait approach with seeing if people will just sort of spontaneously improve. So there's been, some effort in trying to improve diagnosis of iris in the central nervous system using things like neuroimaging. And I think there's pros and cons with using or adding neuroimaging as part of the CNS iris diagnostic criteria. So there's, a handful of infections that we really worry about with iris, cryptococcal meningitis being one of them. And this is sort of an example of what neuroimaging might look like, or this is someone who had cryptococcal meningitis iris. And similar to my first patient that I mentioned, the challenges here are that with cryptococcal meningitis, neuroimaging just shows leptomeningeal enhancement. And so it's very hard to differentiate that leptomeningeal enhancement being from an infection due to cryptococcus versus an inflammatory response. It looks the exact same. And so in this patient here, we're seeing in the sagittal view over here, sort of this thick leptomeningeal enhancement, maybe a little bit of extension into the cortical areas. There might be some small abscesses within the brain or cryptococcomas, but this can look just like cryptococcal meningitis. There really isn't much of a difference here. You oftentimes with these patients or with cryptococcal meningitis might see these patchy changes within the basal ganglia. This is thought to be due to cryptococcus in the vascular spaces, so causing enlargement there. And you might see in this first picture here some enhancement of those vascular spaces that could potentially be seen in iris and a sign of some inflammatory response. But there really isn't much of a difference here between sort of an initial meningitis presentation versus iris. Another example or another area where we oftentimes see iris is going to be in TB. This is sort of a big driver of iris. And this is someone who developed TB iris in the brain. So their initial presentation here, we see an A and B. They're having sort of this classic basilar meningitis. We're seeing this thick exudate around the midbrain, and it's going to be extending into the posterior fossa, probably causing some obstructive hydrocephalus with these enlarged ventricles. And then they came back a couple months later with what we assume is TB iris. So this is going to be our C and D pictures here. But I see a question. Oh, okay, never mind. And C and D, we're seeing them come back with TB iris here. But it's very hard to sort of look at these pictures and know that this is iris. So we see the development of some cortical or focal lesions. These could look like tuberculomas here. We're seeing sort of extension of these hyperintense, maybe edematous changes throughout the brain, a lot of mass effect. All of these things could be driven by inflammation, but all of these things could also be seen in sort of a very severe TB infection. And there's really no way based on the imaging to say iris versus maybe TB and someone wasn't taking their medications regularly. So the neuroimaging might not be extremely helpful here as well. Another example being PML, or progressive multifocal leukoencephalopathy. So this is going to be caused by JC virus. And so the JC virus infects the oligodendrocytes and astrocytes in the brain, and it causes demyelination. And so A and B are the PML infection. And what it classically looks like is going to be these sort of patchy changes in the myelinated parts of the brain. So usually subcortical areas. This isn't the best picture, but the classic appearance is it goes sort of right up to the cortex and then the lesions stop because the cortex is not myelinated. And there isn't any edema. There very rarely is any enhancement because, again, even though this is an infection, it's primarily causing demyelination. And so this is sort of the one example where neuroimaging can actually be very helpful in diagnosing iris. So A and B is what the PML initially looked like. And then this patient came back with iris, and sort of the helpful aspects of PML and how neuroimaging can diagnose iris is that because this is an inflammatory infiltrate, you're going to start to see changes that you don't see classically with PML. So you see here the extension in C, the extension of this hyperintense lesion. You can see how it's going right up to the cortex and stopping, but you also start to see some mass effect. So this is going to be from edema, so pushing on the ventricles, and you're starting to see a lot of little speckled enhancement, not necessarily a specific pattern. And these are both findings of inflammation and things that we don't tend to see just with PML. So in this situation, someone who we originally saw maybe with PML, now coming back with clinical deterioration, and we can compare these two MRIs, we might feel more comfortable diagnosing iris or PML iris in this case. So this might be the one time when neuroimaging can be helpful in making an iris diagnosis. That said, it's not always helpful because there are sort of several different forms of iris. There's paradoxical iris and unmasking iris. And so paradoxical iris is going to be sort of our patients who we're already seeing. They have some opportunistic infection, something going on. They're immunosuppressed. And then they start taking their antiretrovirals, or their immune system starts to reconstitute. And even though they should be getting better, they end up deteriorating and coming back in. And now this infection that maybe we had already been treated seems to sort of be progressing or worse. But you can at least sort of compare initial presentation to this clinical deterioration. Unmasking iris, though, I think is very sort of challenging and almost an entirely different area, and that these are patients who were immunosuppressed but didn't necessarily have any obvious opportunistic infections or otherwise seemed to be doing okay, started taking their antiretrovirals, or their immune system started to reconstitute. And then they get this hyper-inflammatory response to maybe a few sort of pathogens lying around in the central nervous system that weren't necessarily causing any clinical symptoms or any issues. And so their clinical deterioration almost presents as like a new infection. And since part of the iris diagnosis is that this isn't due to an untreated underlying infection, when these unmasking patients come in and maybe they do have some cryptococcus or TB in their CNS, you really have challenge. It's hard to sort of say that this is iris because you still need to treat the underlying infection. You don't have any sort of comparison imaging or prior CSF testing. And so, unmasking iris can just be very challenging. Even in this case of PML here that we just talked about, the unmasking patients wouldn't have already been in the hospital. We wouldn't have those initial MRIs to compare to when they came back with iris. So neuroimaging in some cases can be helpful with iris, but not every case. So given sort of the overall challenges in diagnosing iris, given the fact that especially CNS iris can be sort of quite devastating, mortality rates can be up to like 20, 30% in a lot of these cases, it's can be very important to sort of diagnose iris versus an untreated or poorly treated underlying infection. But given the challenges with the diagnostic criteria being more from clinical judgment than specific criteria, a lot of work has gone into trying to at least understand potential prognostic factors or biomarkers. But the issues with a lot of these tests or studies is that, they're not always done with the CNS issue or CNS infections. And so this is one big study that came out a few years ago, looking at prognostic factors for developing iris, but more systemic forms of iris. And this sort of prospective study looked at a couple hundred patients as they initiate antiretroviral therapy. And it did find that an elevated D dimer at time of initiating antiretroviral therapy or elevated or higher HIV viral load copies were predictive of being more likely to develop iris. They found that people with anemia were more likely to develop iris. So a normal hemoglobin count was sort of more protective. So there were some potentially helpful prognostic factors found in this study, but again, it was only looking at more systemic forms of iris. And since the CNS is sort of a protected and closed space, the systemic factors might not always be representative of what's going on in the CNS space. And so I think this more research is needed to sort of focus on the central nervous system with iris. Other studies looking at biomarkers typically look at sort of specific infections and the risk of TNS or CNS iris with biomarkers. A lot of these studies sort of look at specific infections because even though iris is the umbrella term, the immune response against different pathogens that trigger iris tends to be different, and there really are different findings in what might be a biomarker for TB iris versus cryptococcal meningitis iris. Just sort of highlighting the idea that iris is more of an umbrella term than sort of one specific syndrome where you can develop biomarkers sort of across the board for all the things that might trigger it. So this was a study looking at TB iris. Again, this is not looking at the central nervous system. This is looking more at systemic forms, following patients with HIV who started antiretrovirals and sort of looking at the risks in developing iris. In this top table, they were looking at the clinical characteristics of these patients, and they found that the only sort of significant finding with the people who ended up developing iris versus those who did not, again, was sort of the HIV viral load was an important prognostic factor, sort of higher viral loads more likely to develop iris down the road. They also found that the longer the delay between starting TB therapy and initiating antiretrovirals also was important and sort of protective against iris. So the more you treat the underlying infections or the less pathogen that's present when you start antiretrovirals or immune reconstitution, the less likely you are to get this inflammatory response, the less underlying pathogen is present. They then looked at sort of specific cytokines in the blood, and they found that, these pro-inflammatory cytokines, IL-6, IL-8, TNF-alpha, did seem to be higher in those who developed iris than those who did not. But they measured it over various time points between, sort of time of initiating antiretrovirals and 24 weeks. And as you can see here, the sort of levels of the cytokines varied over time. And so, for example, like IL-8 and TNF-alpha were a little bit more significantly elevated in those who developed iris earlier on in the time course, but that went away later on in the time course, and that didn't always correlate with developing clinical symptoms. And so even though there seemed to be a correlation between higher pro-inflammatory cytokines and iris, which sort of makes sense, you can't necessarily measure them when someone's coming in with clinical deterioration and have it sort of completely correlate because they sort of vary over time. So highlighting the difference between different underlying pathogens and how the immune system might respond to them. This was a study looking at cryptococcal meningitis, so different pathogen, but we're now looking at the central nervous system. And in this study, they were looking at the time of cryptococcal meningitis diagnosis and then those who developed iris and potential biomarkers or other diagnostic test differences. And they also looked at TNF-alpha and IL-6. But unlike in the last study that looked at sort of systemic TB infection, this did not show any significant difference in those who developed iris with these pro-inflammatory cytokines, so might not be helpful with cryptococcus and CNS iris. They also sort of looked at CSF studies and sort of the results of our CSF white blood cell count, proteins, and cryptococcal antigen titer. And I think this is helpful in terms of figuring out how to diagnose someone coming in potentially with iris. So when we're looking at our diagnostic test results and we're trying to figure out, what might be the indicators of either a relapse in infection versus iris, how do we interpret this data? And so in this particular study, they weren't looking at relapse of cryptococcal meningitis just with iris. But they did find the sort of the difference between initial infection with iris, or sorry, initial infection with cryptococcal meningitis and iris was the PMN count. So not necessarily just the CSF white blood cell count, but the PMNs were significantly elevated with iris, but not lymphocytes, which I think highlights just this dysregulated response that you get from iris. They did not find any significant difference in terms of CSF protein. And they did find a significant difference, though, in cryptococcal antigen titer between sort of time of cryptococcal meningitis diagnosis and iris. So those with iris had sort of a significant decrease. It was much lower, potentially indicating sort of more treatment of the underlying infection and that any clinical deterioration is going to be due to an inflammatory response, is how this could be interpreted. But sort of challenging that, there's a lot of different studies looking at this, and the difficulty here is that each different study finds different results. So this other study in table 1, this was looking at 154 patients in China who were treated for cryptococcal meningitis and then started antiretrovirals, and they were looking sort of similarly at diagnostic tests in those who developed iris versus did not develop iris, and how we might be interpreting these test findings. And so here with this study, they did not find any difference between the cryptococcal antigen titer with iris. So they found that it was sort of elevated both in the initial infection and with iris, which is sort of what we commonly see. So this is an antigen test, it's not measuring live fungal infection. And so even though we might be treating the cryptococcal infection, there's still sort of enough cryptococcus in the CSF to trigger sort of this elevated antigen test. And so I typically find that we can't really rely on the antigen titer as helpful in diagnosing an infection versus more of an inflammatory response against the underlying infection. They also looked at the CSF findings, and they did find that the CSFW white blood cell count was significantly different. So it was elevated in iris patients, sort of similar to the last study. But they didn't look at the breakdown in lymphocytes versus PMNs. But they did not find any difference in terms of CSF protein. And so again, it's a little unclear, at least if we're looking at the preliminary CSF results, how are we going to diagnose iris versus maybe an untreated cryptococcal infection just based on these prelim tests. They did, though, look also at these serum sort of biomarkers. They looked at the inflammatory markers, including CRP, and they found that an elevated CRP at the time of antiretroviral initiation was predictive of developing iris. So sort of reaffirming some of those findings from the systemic studies. But they did not find any difference in the viral load. So again, sort of a mixed bag of results here. And this test down at the bottom, or this table 2 here, I think was probably the most helpful study in that they weren't necessarily just looking at initial cryptococcal infection versus iris, but they were trying to differentiate sort of test findings with those who came back with a relapse in cryptococcal meningitis versus iris, which I think is where we oftentimes find the most difficulty in making that diagnosis. And so they did see that there was a significant difference in CSF protein. So the protein was much higher in iris compared to initial infection versus relapse. They found that the glucose was significant as well, although, maybe the glucose was a little bit higher in paradoxical iris compared to relapse of cryptococcus, but I find that that's probably not the most helpful point. But what they also found was that the white blood cell count in the CSF was significantly different. And so there were more patients with iris coming in with a higher CSF white blood cell count. So sort of reaffirming the other studies showing that as the immune system reconstitutes and there are more immune cells that can be recruited into the central nervous system for the sort of hyperinflammatory response, you tend to see more CSF white blood cells than you would in these immunosuppressed patients coming in with an initial infection. So, I mean, it's a lot of different studies, and there's many more that I didn't necessarily comment on. Some of these studies sort of internally contradict themselves, and that positive findings for paradoxical iris might sort of not be found in unmasking iris. It's just very, very complicated and hard to try and understand sort of what the underlying mechanism of action is here, what could be potential biomarkers or even prognostic factors. And so ultimately, iris is going to be a clinical diagnosis that's based on sort of clinical judgment. And there really isn't any great sort of additional points that we can add or I can add here. And I think my interest in iris being trying to create sort of more CNS specific diagnostic criteria. We did a Delphi survey with experts in this area. So this is sort of an iterative survey using a 5-point Likert scale, trying to get some consensus agreement on sort of diagnostic criteria. And so I did this for CNS iris. And I think the interesting findings from the study we did, that sort of writing up a manuscript right now, is that there's so much disagreement that there was even disagreement among sort of the core sort of criteria for iris. So in terms of clinical deterioration, everyone agreed in that clinical deterioration should be present, but the time frame can vary. It can occur sort of weeks after immune reconstitution to sometimes years. There isn't, a lot of agreement in terms of what type of clinical deterioration we're looking for. We are looking for evidence of immune reconstitution, but that can sort of be different. So, for example, with our HIV patients, there should be an increase in CD4 count, but it might be more CD4 percentage and sort of the absolute, or instead of the absolute CD4 count. But ideally, you're finding some form of immune reconstitution in your blood work. The idea that it's not due to an untreated or incompletely treated pathogen, I think, is important, but it's very hard to determine how to do that. You have to rely primarily on clinical history from the patient or their family in terms of how adherent they were to the medications to treat a previously known infection. And you can do tests to see if that underlying infection is still there, but you can't always, conclude too much from that. So for something like TB, TB takes a while to be treated, especially in the CNS. And so oftentimes, even with TB iris, we're still going to find positive cultures. And that does not necessarily rule out TB. So you're really kind of relying as much as you can on sort of patient report of adherence to medications. And then neuroimaging, through the Delphi survey that we did, people agreed that this should be done. It should ideally be done with an MRI, with and without contrast. But again, no one can really agree on what we're looking for with the neuroimaging. And as discussed with those MRIs earlier, sort of evidence of new focal lesions or increased size of lesions or mass effect or edema, all of these things can be seen both with iris or with an untreated infection. And so ultimately, you're really just using your clinical judgment of the patient and the specific situation in front of you. But it can be very challenging, especially with these CNS iris patients, to kind of feel comfortable making a diagnosis. So ultimately, what you're doing is, you're trying to make sure that the underlying pathogen that might be triggering iris is getting treated. And then from there, sort of the next question comes to, if we are worried that there is sort of CNS iris on top of the underlying infection, do we want to treat it and how? And there are limited treatment options for iris. There's different approaches depending on the underlying pathogen, again, sort of highlighting the idea that there's sort of different immune responses or inflammatory responses triggered by these pathogens. We'll talk about different options in these different situations, but most commonly, the best thing to do is to at least try to prevent iris, ideally through some delay of initiating immune reconstitution. And so oftentimes this means, trying to treat the underlying infection for a while before starting that immune reconstitution with antiretrovirals. So there's less pathogen to trigger an inflammatory response. So kind of going over some of the data that exists in treating iris, we'll start with sort of the more prominent data that exists for TB treatment, particularly with prednisone. So this was a study that came out about 15 years ago now in AIDS, a sort of seminal study looking at using prednisone along with the initiation of TB treatment. And again, this is not looking at the central nervous system. This is looking at more systemic forms of TB. And it showed very good results in terms of those who received prednisone versus those in the placebo arm of the study. So prednisone initiated with TB treatment, there was less deterioration over time, greater improvement, less risk of death. And so really highlighting the importance of utilizing prednisone, usually like prednisone 60 milligrams, in addition to your TB therapy. And this was in patients with HIV, but also without HIV, so the importance of prednisone. However, the data is a little bit murkier when we're talking about sort of central nervous system forms of TB and iris. So the study came out in the New England Journal of Medicine, looking at using dexamethasone for TB meningitis and then following them over time. So it was a randomized controlled trial looking at dexamethasone versus placebo to see if steroids helped with sort of survival. And this graph here shows that there was no significant difference in terms of people with TB meningitis who received dexamethasone and the risk of sort of death or adverse events. And so it became very unclear whether steroids, which seem to be very beneficial in more systemic forms of TB, are actually beneficial in the central nervous system forms, especially in people with HIV. So the general guidelines here is really just delaying antiretroviral therapy to try and prevent central nervous system iris with TB. So usually we delay antiretrovirals for about 2 weeks in other forms of TB, but for CNS forms, it's going to be closer to 8 weeks. Otherwise, steroids, again, unclear benefit. The general guidelines are, if someone's really severely sick, if there's, severe neurological disability, we can try to use steroids, but the efficacy is unclear. But, in terms of practical guidance, we oftentimes do use steroids, either dexamethasone or prednisone, to try and help with these patients. In immunocompetent patients, again, we do use steroids, and so there is some good evidence for their use. So the study came out in 2004 in the New England Journal of Medicine. It's a randomized double-blind placebo-controlled trial, 545 patients looking at dexamethasone along with TB treatment. And it did show that dexamethasone along with TB treatment decreased the risk of death. It didn't necessarily decrease the risk of severe disability, though. But at least sort of less risk of death. Again, sort of the benefit in terms of preventing iris is a little bit unclear, but sort of longer term survival benefits. And so oftentimes we will use steroids outside of patients with HIV. And it's going to be either dexamethasone or sort of a prednisone equivalent for 6 to 8 weeks in these CNS TB patients to prevent iris. And this is from the New England Journal of Medicine paper. So just showing that the patients who received dexamethasone versus placebo, again, sort of less death in that group, but in terms of sort of good outcomes versus some disability, their severe or intermediate disabilities are not quite as significant of a difference. So again, we're doing this primarily just to decrease the risk of mortality. Now, in some situations, with TB especially, it can be very sort of refractory. So there can be some refractory cases of TB iris, especially CNS TB iris, where you have someone who is already on steroids. Every time you try and go down slightly on the steroids, they develop sort of worsening, whether it's sort of strokes or increasing mass lesions. These patients are oftentimes very, very sick. And the question becomes, what do we do? You know, the steroids are not helping. They can't stay on these high dose steroids forever, and they don't even seem to be working. And so there is some data on alternative things to treat these refractory cases. So the most data is actually looking at thalidomide. But in all of these instances, they're all looking at TNF alpha blockers. So, you know, potentially the underlying mechanism of action is blocking these pro-inflammatory cytokines. So thalidomide that we don't see too often used here has a good amount of evidence. There was a systematic review looking at all the papers of thalidomide for refractory CNS TB iris, and it showed an 89% favorable response in people who received this when they were refractory to steroids. There was about 24% risk of adverse events. Mortality was about 5%, so not sort of without potential harm, but the adverse events tended to be more like a rash neuropathy and elevated LFTs. There was only one placebo-controlled trial. It did not show any benefit with thalidomide. So again, the data for all this stuff is extremely unclear. The only controlled trial didn't show benefit. Other more sort of case series did. And there was only a couple trials that looked at thalidomide for use in HIV, and they did show that it was helpful in about 82% of cases. But again, sort of a systematic review of a bunch of different studies, sort of not all looking at the same thing. But overall, you know, I have seen in some cases, usually in low-income countries, that thalidomide is used for these refractory cases, and sometimes, you know, anecdotally, it can be helpful. Again, these are things that we really only consider in sort of the worst cases where, you know, the risk of mortality is very high, and we're basically just trying to sort of save someone's life. There's case reports of infliximab being used, more in non-CNS forms of TB with some benefit, and I have seen it used a few times here at Mount Sinai for CNS forms of TB, possibly some benefit. Again, we're talking about case reports, so really this is something that we only use in these rare situations. As well as case reports of adalimumab being used in refractory cases of CNS TB iris to steroids and infliximab, and it did show benefit, but again, just case reports. So things to consider in these very severe cases are sort of other TNF alpha blockers. Cryptococcal meningitis, again, the best thing to try and do with iris is to prevent iris by delaying antiretroviral treatment, usually about 4 weeks or so. So the Cochrane review showed that if antiretrovirals are started within 4 weeks of cryptococcal meningitis treatment, there was a higher risk of mortality, although not clearly due to iris. Steroids are sometimes used. You know, the recommendation from the Infectious Disease Society of America is that, you know, for these very severe cases, potentially steroids could be used and tapered over a 2 to 6 week course, but very limited evidence. And that, you know, there is evidence that steroids used earlier on in treatment of cryptococcal meningitis can actually worsen infection. So this should only really be considered for these iris cases where there's a little bit of a delay in presentation. And then in terms of possible sort of future areas of research for cryptococcal meningitis, there was one study looking at sertraline. In addition to cryptococcal meningitis treatment, there was some evidence that it might sort of block cryptococcal infection in the CNS. It did show that with concurrent use of sertraline, there was increased fungal clearance from the CNS and potentially lower rates of paradoxical iris, but that was not one of the primary endpoints in the study. So again, this is more just sort of a potential interesting finding that might have future use and as an adjunct therapy to cryptococcal meningitis treatment, potentially sort of increasing that fungal clearance, you know, could potentially limit the risk of iris. Another important thing to consider with cryptococcal meningitis and iris is the risk of elevated intracranial pressure. So cryptococcal meningitis obviously causes very high intracranial pressure often through sort of a non-obstructive hydrocephalus or blocking CSF reabsorption. But intracranial pressure can increase not just with initial infection, but it can also increase sort of at any time course through treatment of the infection. It can also increase as a risk of iris. So it's always important to kind of keep this in mind and check the pressures when these patients come in. And if they are elevated, they might need to get serial lumbar punctures or lumbar drains or even shunts. And sometimes shunts are beneficial, especially in these more sort of delayed presentations. Um, there's only one sort of larger study looking at the use of shunts in cryptococcal meningitis. This came out in the Journal of Neurosurgery, looking at about slightly over 50 patients who required a shunt due to cryptococcal meningitis. It was not looking at iris per se, but they did show that overall they had very good outcomes with shunts. Not many complications. It did not sort of cause a disseminated infection. And I put this picture in only to show that, of the initial patients who had sort of normal intracranial pressure at presentation, of which there were 17, two of them ended up having sort of delayed raised intracranial pressure that started sort of several months out and ended up still requiring shunts. And this was in addition to all the other patients that they saw who had raised intracranial pressure earlier on that it was refractory to the serial LPs or drains and still required shunts. So again, this can be sort of a very delayed effect that we see months later. PML, so another one of those opportunistic infections where we worry about iris. Unfortunately, this is not a situation where we can delay immune reconstitution. The only treatment for PML is sort of bringing the immune system back, letting the immune system control the JC virus. So you have to start antiretrovirals or whatever immune reconstituting medicines are needed as soon as possible. Again, there's very limited evidence on things to use for PML iris. There was the review of studies looking at steroids that came out in the Journal of Neurology that showed that overall steroids did not seem to be beneficial, but there was no randomized controlled trials. And in general, they didn't show any harm. And so I personally oftentimes will use steroids with PML iris in very severe cases. And, again, sometimes it seems to help. These are anecdotal cases. This is not sort of a recommendation, but I do think similar to Cryptococcus and TB, when these patients are sort of very, very sick, have, extreme disability and potential risk of death from their iris, sometimes giving the steroids a try is reasonable. There's also been some case reports looking at Maraviroc, which is a CCR5 antagonist for PML iris with sort of mixed results here. So for PML iris, in those severe cases, would probably recommend starting steroids first. So overall, limited evidence for managing these CNS iris cases that are very complicated. Steroids seem to generally be the first line, despite sort of a lack of strong evidence. But again, when patients are quite severe, if there's high risk of disability or mortality, oftentimes reasonable to give these things a try, and sort of steroids generally first line, with TB showing potentially other things to try with the TNF alpha blockers. Now I don't have a ton more time, but I do want to just sort of talk a little bit about sort of non-iris situations, primarily viruses, things that can sort of trigger neurological damage and neurological deficits, potentially through an inflammatory mechanism. There's sort of a long history of sort of viruses having this complicated interplay between the immune system and that leading to neurological damage, whether it's encephalitis lethargica from 100 years ago that occurred around the time of the influenza outbreak, that we still don't really know what caused encephalitis lethargica, but seems most likely to be due to influenza, maybe some post-viral process. We have post-infectious encephalitis and myelitis that we commonly see in patients after maybe they have a vaccine or some other viral infection where they come in with these complications. And then more recently, there's been reports of people with HSV encephalitis who go on to develop an NMDA receptor encephalitis. And so it seems like the immune system response against HSV sort of triggers these autoantibodies that further attack the nervous system. And so all these things highlighting the complicated interplay. All right. So just for the sake of time, I'm not going to go into all the details of VZV. What I will say about VZV is that sort of the interactions with the central nervous system are sort of complicated and nuanced, and you can see different things with CNS complications from primary infection, from reactivation, and then this is also a virus that you can see triggered with iris as well. Um, a lot of these CNS complications are thought to maybe be more para-infectious. Again, the evidence is sort of limited with all these things, but I'll sort of highlight the differences between these manifestations. There's cerebellar ataxia, which oftentimes occurs in children with primary infection. Primarily it causes the sort of ataxia syndrome. And it's not fatal. Symptoms tend to self-resolve within 1 to 3 weeks, not even necessarily with treatment. And so this is primarily thought to be more of this para-infectious immune-mediated syndrome. It's thought to maybe cause some demyelination, but not anything severe, sort of resolves on its own. You can also see an encephalitis with primary infection. This you can actually see intranuclear viral inclusions on autopsy studies. So you do see evidence of virus within the CNS. And testing for this is going to be sort of looking more at evidence of the virus with CSF PCRs and not so much with CSF antibodies. But again, this is from primary infection, and so there might not be enough of an antibody response sort of mounted yet to see that intrathecal production. So this going back, you do not see intranuclear viral inclusions here with this. So sorry, just highlighting with the primary infection, you don't see much virus on the autopsy studies, but you do test for the CSF PCR and not the antibodies. Now, encephalitis with VZV reactivation. So again, similar presentation, but this is going to be the latent virus reactivating. CSF PCR can be very sensitive and might be positive, but not always. And sometimes it's beneficial to also look for intrathecal antibody production and testing for those antibodies. And in this case, you do oftentimes see virus within cells on histology. So you see intranuclear inclusion bodies present. And then there's the vasculitis or vasculopathy that VZV can cause that affects medium and large vessels, where you can see strokes and TIAs. And here you will see evidence of the virus within the cells of the blood vessels in the brain. But sort of interestingly, with the vasculitis or testing oftentimes needs to be looking at IgG for VZV. So there are many sort of reports of VZV vasculitis where PCR is most commonly negative. IgM is also most commonly negative, and it's really the IgG that comes back positive. And so sort of comparing this with the other forms of EZV complications and encephalitis, I think this sort of highlights that immune response to the infection and that the virus can be present, but it might not necessarily be doing sort of damage. And it's more the sort of long-term antibody response to the virus that maybe causes this inflammatory sort of damage. So in general, when we're thinking about VZV, I do recommend testing both PCR and antibodies. So it can be hard just looking at the patient in front of you to know whether this is kind of primary sort of viral infection causing damage versus more of an inflammatory response. And so it's oftentimes beneficial to just send all of the tests. Also, the time course can be important, so the natural evolution of how these tests sort of work best is at play. And so for VZV and many other viruses, or that first week of clinical symptoms, that's when the viral load's going to be the highest, when PCRs are going to be most likely positive. And then from there, you start to develop this IgM response. And so antibody testing, particularly to IgM, can be most beneficial. Treatment for CNS VZV complications is really going to be acyclovir. That's sort of what we commonly use, although there really isn't great data for it. But in general, we recommend using our standard acyclovir usually for like 10 to 14 days, but there might be some evidence that our immunocompromised patients should get potentially up to 21 days of treatment. Otherwise, there's really not any great data on using steroids. Steroids could potentially even worsen infection. So we really just avoid using those immune therapies for VZV and tend to focus more on acyclovir, which even if it's para-infectious in etiology or inflammatory related, that acyclovir can decrease the viral replication. So even a little bit of virus triggering an inflammatory response, the antivirals might sort of limit that response and as a result, potentially sort of help improve the symptoms. Again, for the sake of time, I'm going to just sort of skip through a lot of this. I want to just briefly touch on enteroviruses. Enteroviruses, are very common, most commonly cause encephalitis and meningitis, but can be sort of benign and self-limiting. But there's many different subtypes. And recently we've seen a few different subtypes that can cause quite devastating neurological disease. And each of the subtypes sort of has a predilection for different parts of the brain here. We have enterovirus encephalitis seen with the A71 subtype. This is very common with children, commonly affects the brainstem. Thought to have some sort of immune system mechanism of action due to sort of immaturity of the blood-brain barrier and this sort of pro-inflammatory cytokine response causing a breakdown of the blood-brain barrier. And we also have the D68 subtype of enterovirus, which we saw recently causing this acute flaccid myelitis outbreak, which sort of looks like polio. Um, I think the important thing here, highlighting this, is that this acute flaccid myelitis outbreak, this sort of looks similar to polio. There's a lot of clinical overlap with things like Guillain-Barré syndrome or an acute transverse myelitis. It can be sort of challenging to diagnose enterovirus, the etiology of this clinical presentation. So the diagnosis here from this article in The Lancet really relies on sort of clinical factors and then ruling out other etiologies such as neuroimmunology etiologies. But you usually can't find enterovirus in the CSF. And so you're relying on the diagnosis here by finding evidence of enterovirus infection, either respiratory swabs or stool testing, so more of a systemic infection, and then evidence of that infection correlating time course wise with these neurological symptoms and sort of general findings of elevated white blood cell count in the CSF. That's generally how this diagnosis is made, but very rarely do we get a positive PCR to these subtypes of enterovirus. And so this, similar to other infections, even like neuroborreliosis and Lyme, oftentimes highlights even a little bit of infection in the central nervous system might trigger the strong inflammatory response that can cause the damage, but that potentially might be why PCR tests are a little bit less useful in the CSF testing. And antibodies might be more helpful because you're just finding more evidence of that inflammatory response. Again, sort of the underlying mechanism of action here is not quite clearly known, but there's reasons to think it might be due more to underlying inflammation. In terms of management, a lot of different studies have looked at things like steroids, IVIG, plasmapheresis. All of them have shown potentially some benefit. They definitely don't seem to cause any harm or worsening outcomes. So worthwhile to try if you have any of these patients. Sort of maybe the best evidence is for IVIG in these enterovirus patients, but this was sort of a retrospective study. It did show, though, that 95% of the patients who survived the CNS complications here did receive IVIG, but potentially steroids or plasmapheresis are also helpful. And then supportive care can be beneficial. And I won't go into this, but milrinone was shown to possibly help as well for the sort of cardiac complications. And then since it's basically time, I will just sort of basically say that for influenza, very similar to enterovirus, where the diagnosis is going to rely primarily on finding signs of a more systemic infection along with CNS complications. Similarly to enterovirus, steroids might potentially be beneficial, but we're really just looking at small case series here. IVIG, unclear to help. And then tocilizumab, there was a small case series where 2 patients recovered with this, but again, not a lot of evidence. And basically the same goes for West Nile virus. There's sort of a lot of overlap with these infections as well. All right, for the sake of time, I will just sort of wrap up there. But
Thank
yes,
you so much. That was very extensive and amazing. I'm sure if there's questions, is it okay if the group emails you directly?
yes.
And the one question I had is there a way if we have some of these patients in our ICUs, are we supposed to be consulting just general neurology, ID? Can we email you directly, or is there a
Yeah,
pathway?
you can email me directly. I mean, oftentimes the neurology consult service will also ask for my help or assistance if they think could be beneficial, but you're more than welcome to also reach out directly.
Okay, well, thank you so much for this amazing lecture, and we'll have to have you back again soon to hear some more. But we really appreciate your time.